Good morning, everyone. I'm Louise Shaner, Policy Director of the Hutchins Center on Fiscal and Monetary Policy. I'd like to thank you all for taking the time to come out to Brookings this morning to join us in this conversation about reining in prescription drug prices. We're really excited about today's event, and I hope you will find it informative and thought-provoking as well. One thing I have learned during our work putting together today's event is that issues involving prescription drug pricing are really complicated. Who knew, right? So, before we jump into the proposals about ways that we might reform drug pricing, I just wanted to give you a little background on the issue that we'll be talking about this morning. And I also want to point you to our website. We have what we call Hutchins Center Explains, an explainer on prescription drug pricing that will go over some of the same issues that I'm talking about this morning. Okay, so drug spending in the United States. Retail drug spending, that's drug spending at pharmacies, was $325 billion in 2015. Okay, that's about $1,000 a person and about 10% of total health spending. On top of this drug spending that we do at pharmacies, there was an additional roughly $125 billion spent on pharmaceuticals that are administered in physician offices and hospitals, so about $450 billion altogether. Okay. Now, prescription drugs were not always such an important component of health spending. So if you go back to 1980, for example, drug spending was only about 5% of total health spending, and that's climbed over time, and now it's about 10%, and projections are for it to continue to climb, although slowly over the next decade. So one of the things that happened as drug spending became a more important component of health spending, and as health spending became more and more expensive, so the drug spending was becoming more and more expensive, insurance markets changed. Right? So it used to be a lot of people did not have prescription coverage for drugs, right? But as drugs became something that actually presented a big financial risk to people, insurance began increasingly to cover it. And for Medicare, up until 2006, Medicare didn't cover prescription drugs, and in 2006, Part D was introduced. So if you look at what share of drug spending is out of pocket. When you go to pick up your prescription, the amount you have to pay your co-pays, your co-insurance, you still have a deductible, what share of spending is sort of paid for at the time that you pick up that prescription? In 1980, it was about 70%, right? And it's fallen dramatically over time, so that now the out-of-pocket share is something close to 15%. Okay, what does that mean? Well, it means people have more protection for drugs, so that's a good from the perspective of risk, but it also means that consumers are increasingly insensitive to the price of drugs when they decide whether or not to fill their order or when they talk to their physician about what drug to try, right? And that will come up later today as something that sort of affects policies related to drug spending. Okay. Like everything else in healthcare, we spend a lot more in the United States per person on drugs than other countries do. So as I said, we spend around $1,000 a person in the United States. In Japan, Canada, Germany, they're like less than $800 a person. And if you go far to the right, to Denmark, they're only spending $325 per person. And a lot of that is because we have high prices for drugs. Okay, not all of it, but a lot of it. Okay. What are the basic economics of drug development? So I think the biggest thing to remember is that there are large fixed costs to invent and test new drugs, right? So you've got to invent the drug, and that's a lot of R&D, and then you have to pay for very extensive and very expensive testing to make sure that the drug works and that it's safe, to get it through the FDA approval process, and that's very expensive. And when you start the process, you really have no idea if you're going to get much of a return on your investment, right? A lot of drugs fail before they get to all the stages, right? They fail all along the way. Right, so there's a huge uncertainty about the likely returns to R&D. Now, once a drug has reached the approval stage and you're ready to market it, in general, not for all drugs, but in general, the marginal cost to produce the drug, right, what it actually costs you to put out another pill, are very low. So what does that mean? Right, it means it's an industry where most of the costs are fixed cost that have to be taken years before. And without regulation, no one would want to invest in pharmaceutical R&D, right? Because if you invested and you had this new great drug and there was no protection, somebody else could just come in and undercut you. You get to a price war where you'd be pricing at marginal cost. You'd never recoup your investment, okay? So the regulations that give drug companies market power are kind of interesting. So like all intellectual property, you can get a patent on an invention of a drug, right? And patents last 20 years from the date of filing, and that time is sort of not even related to drugs, right? It's just very general. At the same time, kind of a parallel path, the FDA provides something called exclusive marketing rights that also give you the exclusive right to market a particular drug, and they give that for a certain length of period, and that starts once they've approved a drug. Now, that length of the exclusive marketing rights does depend on the type of drug, and drugs in small markets, so-called orphan drugs, which you probably will hear more about today, are given longer rights so as to encourage innovation. Now, after both your patent and your exclusive marketing rights expire, and it could be either one sort of being the longest one, then generics can enter the market, and then we have a more competitive environment, okay? On average, brand name drugs have about 13 years of sales before a generic competitor enters the market. Okay, there are a lot of trade-offs when you're thinking about drug pricing policy. Okay, there are the trade-offs between the incentives that you want for innovation, between access issues, which is you don't want really high prices that will make it hard for people to get the drugs, and there's also an issue of fairness, which is a little bit different, and I'll explain. Okay, so as I said, we need higher than normal profits, and we need prices greater than marginal costs if we're going to encourage innovation, right? Pharmaceutical companies have to be able to recoup their investment. Okay. But high prices limit access to drugs. That's the trade-off, right? They increase out-of-pocket costs, and they also increase insurance premiums. And there's another wrinkle, which, as I showed you before, high prices also make generous insurance necessary, but insurance also leads to too little price sensitivity on the part of consumers. And then there's an issue with fairness, which is different than the issues of access or innovation, which are kind of efficiency considerations, which is that monopoly power might allow drug companies to reap too much of the benefits of new drugs. So take an example. Imagine there's a drug that costs $500 to produce per drug. Once I can include all the costs I've been talking about, sort of getting back your cost of innovation and sort of a reasonable return on the projects that didn't work, like $500 is kind of a social value of producing that drug, the social cost. But consumers value that drug at $5,000. That is a great innovation, right? It costs $500. It's worth $5,000 to consumers. Okay, let's say that drug is priced at $4,900. Okay, if you looked at that drug, you'd say, oh, it's $4,900, but it's $5,000 worth of benefit. It's still worth it. It's still something that consumers should buy. It's still a good deal for them, but kind of just barely, right? So they get $5,000 of benefit. They're happy about that, but the drug is going to seem really, really expensive, right? And meanwhile, most of that benefit, the difference between $4,900, the price that they're charging, and $500, the cost, goes to the drug manufacturer. So the question is whether or not there are trade-offs here where we might, even give up a little bit on the incentives for innovation in order to get sort of what some might feel is a more fair distribution of the social benefits from innovation. Okay, so what can be done? So let me step back and tell you, why did we have this conference? Why did we think about asking people to write proposals? So, you all know that there have been a lot of stories in the press about brand name drugs that are very valuable coming on. People value them, but the prices are kind of shockingly high, as well as the stories that seem really hard to explain about people like Martin Shkreli buying up old drugs. They didn't do any of these innovations. They didn't bear any of those costs, and figure out a way to use the system, essentially, to jack up the prices like 600% or more, right? So I think there's a lot of desire on the part of consumers and government to take steps to rein in drug prices. We thought, well, if people are talking about doing something, this is a good time to ask the experts what can be done. And in particular, what can we do that might rein in prices without unduly harming innovation? Okay, so we went and we said, okay, let's just find really great authors to come up with their proposals, what they think is interesting and a good idea and they'd like to write about. Nobody came to us and said, the drug industry just needs to be completely regulated. We need to set all prices. No one proposed things like that. All three of this morning's proposals recognize the need for drug companies to retain significant market power and recognize the large benefits that as a society we get from drug prices, right? They recognize the trade-offs, okay? But their proposals are sort of suggesting changes in areas where drug company market power might seem larger than is socially optimal that can be justified. Okay. The authors are going to present their papers to you this morning, but frankly, they don't have that much time. And so they will give you, I'm sure, a very good summary of their papers, but I really encourage you all to read the papers because they're wonderful and they're well written. We're really happy with them, and they're available on our website, so brookings.edu/Hutchins Center, and you can find the papers, and I really encourage you to do so. Okay, so with that background, I know we're all ready to hear about the actual proposals. And before I turn it over to Paul Ginsberg, who is director of the Center for Health Policy here at Brookings and our collaborator in this event, let me just quickly go over this morning's agenda. So as I said, each of our authors will present the proposal, and there'll be some limited time for question and answers. I will then come back and spend some time talking about the proposals and the broader issues that they present with a panel of experts who brings a lot of insights from the field. Practical insights into these questions. And then finally, David Wessel, the director of the Hutchins Center, will talk about the politics of drug price reform with former Congressman Henry Waxman, who played such an important part in encouraging innovation in prescription drug pricing. If you've heard of Waxman? Waxman Hatch? I can't remember. You know that he's really been a real innovator in this area. Okay. I'm really looking forward to this morning's program, and I hope you are too. Again, thank you for coming, and I'm going to give it to Paul.
I'll wait for this. Testing? Okay. I'm really pleased to introduce Richard Frank, who is the Margaret T. Morris Professor of Health Economics, the Department of Health Policy at Harvard Medical School. He's going to present the first paper, which is going to be about a framework for negotiation of prices in Medicare Part D. And Richard Zeckhauser, his co-author, will be participating in the discussion.
What? Oh. Okay, thanks. Thanks, I'm delighted to be here, and I'm going to take a few minutes and sketch out the ideas that Richard Zeckhauser and I have developed. What I'm going to do is first, I'm going to spend a couple minutes just outlining the problems related to pricing and spending in Part D. Then I'm going to focus very specifically on an area where we think there are particular distortions and inefficiencies, which is what we call market power under nearly complete insurance, and we've given that situation the acronym MISC, Monopoly Insurance Subsidized Consumption. And that means market power where insurance is complete means focusing on the reinsurance section of Part D. After explaining why we focus on that area, I'll outline specifically how we propose that negotiations take place and the framework within which that happens, and then I'll make some concluding observations. So this is a graph of price indexes in Part D. And really the thing to note is that top line is unique drugs unique branded drugs. And what that shows you is that it's really those drugs that are pulling up the whole price index. So it's that set of unique branded products that don't have a lot of competition that have rapidly accelerating prices, and they're large enough so that they offset all that stuff from generics that are driving down prices. This shows you what has happened to the reinsurance segment of Part D over the last 10 or so years. So in 2007, it was about 25% of all Part D spending was in that reinsurance segment. Today, it's over 56%. And so there's been more than a doubling in those 10 years. And it's really the combination of those things that are driving us to focus where we are. So let me just remind you what the reinsurance section looks like. And it's what we call double insurance. So consumers are subsidized to the tune of 95%. That is, they pay 5% out of pocket. Plans are subsidized to the tune of 85%. That is, that they're spending they're at risk for 15%, and so the government is picking up 80%. Okay, and it turns out that about 65% of that reinsurance benefit was paid out for high-cost drugs, according to the Office of the Inspector General. And by high-cost drugs, we mean drugs that cost at least $1,000 a month to take and to use. Okay, so when you sort of put those things together, the graphs and the structure of the reinsurance program, it leads to rapid price increases. And so if you look at that doubling of the share that I just told you about, over 90% of that was due to price increases, not quantity increases. And the number of people entering the reinsurance scheme as a percentage of the total enrolled population has remained roughly constant over time. So that really emphasizes the price driving. So there are two types of incentive distortions that occur under these circumstances. The first comes from just the fact that plans face very little risk. And what that does is when you think about the subsidy combined with the possibility for rebates, combined with some of the allocation rules that are contained in Medicare Part D, there's an incentive for formulary placement that doesn't necessarily lead to the lowest cost drug being put in a favorable formulary position. And what that means is that the incentives are set up so that what is low cost to society is not necessarily low cost to plans, and therefore you have a misalignment. The second issue focuses on what Louise was talking about, which is that combination of having market power granted through the patent system accompanied by almost complete insurance. And let me sort of go into that. This is the obligatory nerdy part of the talk. So if you look at the left-hand side of the graph, that portrays a patent monopoly under conditions where there's no health insurance. And so that is the way the patent system is designed for almost every other good except for prescription drugs. And what you see is an equilibrium profit maximizing combination of price and quantity of P0, Q0 up there. Now, later on, and one of the things to notice about that is if you compare it to the competitive part, which is QC, right there, what you see is one of the distortions that people are worried about that Louise mentioned is that the competitive quantity was quite a bit larger than what would happen under that monopoly price. So the good part of insurance is that it corrects that distortion, and so you see that by the movement of the demand curve upward. But you'll notice that the new quantity, and the new price are much higher on both accounts. And in fact, the distortion might get overcorrected, and so there'd be a distortion in the other direction. The price, it turns out, is much higher, and it's much higher in a known fashion. It turns out that under reasonable assumptions, the distortion in price is proportional to the copayment. So in this case, the distortion of the insured price over the monopoly price is a factor of 20. So again, as Louise mentioned, anytime you start talking about talking about doing something about prices, you have to start worrying about profitability and research and development and the incentives there. And so there's strong evidence suggesting that of a positive relationship between profitability and new drugs, at least in terms of number of new drugs, and in terms of higher spending on R&D, and there's good evidence on both. There's also evidence suggesting that that relationship is subject to diminishing returns, and Fiona has produced some of that. And more recent research has shown something else, which is that of the new drugs that are launched from that additional profitability, only a few of them are really truly novel drugs. And so as you read that literature, it's hard not to walk away with the sense that the signal of profitability and innovation is a very weak one, that you get more stuff, but it isn't not necessarily the best stuff. So what we propose to do is we propose a very targeted and temporary approach to negotiated prices. Our target is those high-cost drugs with market power selling in the reinsurance benefit. So that's actually a fairly limited number of drugs, but they count for a lot of money. But they're limited in number, which makes it practical to actually negotiate over them. The second thing we do is we propose to constrain the government's ability to exercise monopsony power by requiring that economic profits, that prices can only be accepted if they, in a sense, guarantee economic profits, which is that incentive to innovate. And what we do is we cover all drugs, and therefore it's mandatory, but we specify a default price, which does two things. One is it keeps people from the industry at the negotiating table, and it also allows us to pay on value and create a bonus scheme for drugs that really do a good job that helps us with that profitability value signal. This is the second nerdy part of the program, which is these are the details of the pricing scheme. And really, the unit price has three components. The first is the default price, which I mentioned, which is set by the government. The two other pieces are the standard for performance. That is, we want to pay on performance, and then the question is, what is the standard for each therapeutic area that you want to set? What is that schedule that will allow payouts to occur? And then the third component is, what is the size of the bonus that you give for reaching different milestones? And those two would be subject to negotiation. Now, key here is how you set the default. And we considered three possibilities. The first was to kind of mimic what's done in Europe, which is to sort of go out there, see what everybody else is doing, what all the other countries are doing, and then set the standard that way. We dismissed that because we were uncomfortable with the potential distortions that creates in launch strategy. The second approach was to sort of do, for prescription drugs, what we do in most other parts of Medicare and what most of the rest of the world does in their insurance schemes, which is to have sort of an ad hoc pricing scheme. And then we were uncomfortable with that as well. And so the third one was to set the default price as a portion of the typical costs of R&D and bringing to market a drug of a particular therapeutic type. say, an arthritis drug or something like that. And so under this scheme, the base price would be set, but then the two other components would be subject to negotiation. And so the negotiations would really focus on sort of that pay-for-performance part of the pricing scheme, and it would be done in a prorated basis on the basis of volume. That thing hasn't moved in a long time. So let me wrap up by saying, for the most part, we don't touch a lot of Part D because, in fact, the market works pretty well, and there isn't a particularly obvious alternative. What we do is we focus on the places where we think the incentives are most distorted and most subject to market failure, and sort of really put our attention on a scheme where we think you could make a correction that would enhance welfare and do so in a way that leaves enough incentive for innovation to continue the flow of good drugs and, in fact, send a more positive quality signal. The negotiation structure creates incentives to bargain on one hand, but also constrains the government's ability to exercise monopsony power and generates economic profits and expectations. From the numerical examples that are in the paper and the ones we've explored, we believe that there are meaningful savings here and rewards from this targeted approach and can be done in a way that preserves substantial incentives to innovate. And that was, in a sense, that point Louise made, saying rather than giving all the surplus to the companies, let's split it up a little differently than we might typically do. And finally, the negotiated arrangement, we can do variations on this theme. And one important variation that we will continue to explore is a scheme where you negotiate the upfront payment dramatically based on performance and industry costs, and then leave prices closer to marginal costs. But that's still work to come. So I'll stop there. Thanks.
I want to introduce Richard Zeckhauser, the co-author of the paper from the Kennedy School at Harvard. And let me get started with a question for one of the authors about what are your thoughts about how a Medicare approach like that would affect private insurers' payment for drugs?
Well, first, I think there are two things to talk about. One is the private insurers within Medicare Part D, and the other is general private insurers.
Outside of private.
Well, let me just, in Part D, I apologize to the American transportation system, apologizes because I was late. But within the plan, I presume you mentioned the fact that in the reinsurance range, the pharmaceutical plans are heavily subsidized. So they're going to behave an awful lot better because they're going to have incentives. I mean, it would be a wonderful system as somebody who is selling a product to get 80% subsidy from somebody else when you're providing your product. Think of what Walmart would be charging for its certain types of products. But Medicare really does play a major role in influencing everybody else. And, you know, a drug that we used to charge $4,000 a year for, which we're now charging, you know, $1,000 a year for, will have ripples throughout the system. And there's no way. I mean, I don't think that water always reaches its own level because there's sort of, you know, bogs and clogged pipes and so on and so forth. But water sort of reaches its own level. So I think that this program for what I would call, Richard, he called them MISCs, M-I-S-C-S's. I would call them miscreants, okay? And for the miscreant drugs, we're going to do an awful lot better. And you're not going to be able to stand up in the world and say, you know, we're charging $4,000 for this drug, which Medicare Part D is paying us $1,000 for.
Thanks. Let me go to the audience for questions. And do you have a microphone? Okay. Look at that gentleman here.
Oops.
That's okay.
He'll get his chance.
What information do you need from industry about costs?
Yeah, I think you would need information from the industry. There is some out there. There is information from abroad. There's a variety of information out there, but clearly some of it is private, and you would think that might be therefore a subject for negotiation. On the other hand, you want to make sure that it's not any one firm's cost you're looking at when you do this. So you're doing it for the average in a therapeutic area, and so that would require sort of some data gathering, data collection.
Can I just say, from a pure theory standpoint, what I would like to do if these 4 people were producing drugs in an area, I'd like to ask each of them for their costs and sort of say that cost is going to be given to your competitor and it's going to have no role in what you get reimbursed. And that's a system which, you're a little worried that your competitors are going to get, paid more than you are. So I'm not suggesting that we use that system. I'm just sort of suggesting that Richard's a very clever guy and I'm trying to put things in his mind.
Okay.
Herb Rose, excuse me. You spoke briefly about novel drugs without defining what a novel drug is. And how does a pharmaceutical company know what is going to be a novel drug until they've invested the time in developing it and testing it?
Well, first of all, the research that I was citing used the FDA definition of novel. So, I didn't make that up, and being a country economist, I wouldn't know the biochemistry of it. I do think that to think that companies only know that they're going for a novel drug after the fact is kind of incorrect. I think that going after a new mechanism of action versus an existing one is an important distinction, and that's the way I would do it. I mean, it's a little bit like the Olympics. Sometimes you run really fast and you get the gold medal. Sometimes you get the bronze, and even though you were trying to get the gold, but sometimes you're not even trying; you're just trying to finish.
Diane Silber. Can you explain the discrepancy between prices in the U.S. and other parts of the world from the same drug companies for the same drugs?
Yeah, well, we don't negotiate. Is one big piece. We've delegated negotiation to prescription drug plans, and sometimes they do very well when there's a lot of competition. But in the cases that we're focused on here, that's the place where you would see the biggest disjuncture between our prices and any other prices.
We don't negotiate. We're the world's major drug producer, which gives us an incentive to pay more. Drugs are also more expensive in Japan and Switzerland, which are major drug producing countries. And we have subsidies all over the place, which makes the various participants less sensitive to the price of drugs than they otherwise would be.
There's a gentleman over there.
Zach Struver from Knowledge Ecology International. You've drawn from prize fund approaches in terms of incentives for innovation. So I'm wondering what your thoughts are on a full delinkage approach that would delink the price of drugs from the cost of research and development.
Well, Richard mentioned at the end of his talk the possibility of giving you a big upfront payment and then having marginal cost pricing. I mean, there have been a variety of proposals on a lot of patents. The patent system is the second best solution. We want you to go out, you're the age to come up with some great IT patent, okay? But when you do, you're going to charge a lot of money for it, and the proposal is that, the federal government should give you $5 million, and then you would charge, 50 cents for it, which is what it costs to produce. Actually, there's more promise for that approach in drugs than there is in IT solutions, because the government would be, as a major payer, would be saving money at the same time that it was paying out this lump sum. Is that possible? I mean, we think of what, you may not be old enough to remember, of Buck Rogers Solutions, okay? Buck Rogers was sort of a space ranger with power race and the like, and we like to think of those things. Australia actually has a scheme that's like this. Australia says, come to Australia, you can sell your drug for any price that you want to sell it, or we will give you $5 million and you'll sell it at marginal cost and it will be part of our drug scheme. And it seems to work pretty well. But Australia's on the other side of the world and it doesn't produce many drugs itself.
There's also a budget problem. Because you'd have to put very large schemes up front onto the federal budget, and that at the very least is politically fraught.
Yeah, sure. Steve?
Your question is a good question.
Hi, I'm Steve Pearson. First of all, I love the way that you've helped suggest that we focus attempts to think about pricing. It's a very important perspective, and I know it in some ways it goes all the way back to your paper, Richard, with Joe Newhouse about unique drugs back when Part D was created. And I also understand this idea of a default price that would cover somehow the cost of development with some kind of reasonable profit. I do worry a little bit that since risk is the one thing that corporations like the least, that they would go after the 19th drug in a category knowing that they're guaranteed a default price. They don't have to worry about market competition a little bit. But I want to focus on the second piece. You've decided to suggest a floor, if you will, and then a build up, which would be negotiated. Other people have obviously thought of a ceiling price that would reflect the margin, basically the high end of what the society would consider as reasonable value, and let the companies price lower if they wish for market reasons. I'm just a little bit worried about what the negotiation, quote unquote, looks like with the floor price going up, unless the government is going to use some very explicit metric for, we'll give you this much more for so many QALYs or other measures of health gain. What does it really look like? A drug company says, I want $200. How does the government say that that's right or wrong? How does that really work unless the government decides that it has a fair, transparent approach to deciding that build up?
Yeah, I think the idea is exactly what you said, which is that B sub Q, that bonus payment, is a schedule that would be negotiated. So it would be set out clearly. But the question is, in a sense, because there's a lot of private information through the testing and things about how something works as it starts, you want to sort of have a negotiated schedule because you use more of the information, and then as the drug comes out, you would revisit it as you saw the actual performance on the ground. But it would be very much, as you say, going up. What we're concerned about in the top-down approach is that, as Louise mentioned at the beginning, most of the surplus in these markets is going to the companies. And so if you start up there, you're more likely to wind up with a large portion of the surplus going back to the companies, which, in a sense, I think, at least our analysis suggests there's too much of that going on right now.
Can I say a word on that? First, the default price would not be such that you would be making a significant profit. The full price would be, actually, we talked about having the full price so that you aren't making a profit. You have to participate in our scheme to do okay. The difference between a ceiling and negotiating down and a floor and negotiating up, if they reach agreement, economic theory would suggest that they would be the same. The benefits, I believe, of having a floor price and going up is that if you won't agree, then you get the floor price, and that's okay with us. There's also, if you worry about Tversky Kahneman sorts of types of things, people like getting more. They hate taking less. I would, every year my dean writes me a letter And he said, oh, you did a great job last year. By the way, everybody else in my school gets roughly the same letter. You did a great job last year, Richard. We're so happy that you did A and B and C. And by the way, we're going to raise your salary by this amount. You could imagine how he would feel if he sort of said, now this is the standard for full professors, but you weren't as good as Richard Frank. So we're taking $9,000 away from you. Well, not bad. I mean, not bad. I mean, we took $11,000 away from Harry, but Richard Frank was the only one who got the top. I would hate that. I wouldn't even teach my class the next year.
Good. Well, we're out of time for the session, so thank you.